Dr. Evelyn Cesarotti holds nursing degrees from the University of West Florida and a PhD from the University of Arizona in Tucson. She's written numerous articles on the subject of asthma in children, hypertension in African Americans, health behaviors in Mormon women, this should be interesting, and Alzheimer's studies, which is her topic today. She's currently a professor at ASU, and she's going to tell us about some of the recent studies in Alzheimer's disease and latest therapies, what are the causes and so on. So I know a lot of people are very interested in this. I don't think there's probably anyone who has not been touched by this dreadful disease somehow, and some family members. So without further ado, I would like to introduce to you Dr. Evelyn Cesarotti.
Good morning. I'm very delighted to be here today to meet all of you. I don't think I've ever spoken for this group before, and it's such a wonderful place to come this morning with all the flowers blooming and the delightful scenery. I live on the west side of Phoenix, and I commute every day over to ASU to teach. And as a nursing professor, I'm teaching the advanced nurses who already have a license in nursing, who are getting their master's degree and specializing in family nurse practitioner. And a family nurse practitioner can practice and treat. Some of you may have family nurse practitioners or nurse practitioners at your doctor's office. We work in collaboration with physicians, but we do diagnosis and treatment and prescribing medications for acute and chronic illnesses. Now, we are doing research in a number of areas at the college, and although we can participate in biochemical research, that's not my specialty. My specialty is looking at, and for most nurses, at the effects of diseases on families and the patient and the effects of the treatment. So I'll be talking a little bit more about that later, what I do. I first became interested in Alzheimer's disease because in Arizona we've been very progressive in this area. Sun City for many years participated in donating brains for the study of Alzheimer's disease for the biochemical research. Many years ago they started that program, so their brains being studied for years here in Arizona. And so a lot of the research findings came from those original studies. We have Sun City research centers still working on many aspects of Alzheimer's disease. I personally am working on aspects of treatment and care of people in advanced stages after they're admitted to assisted living. And in 1995, the Alzheimer's Association sponsored a grant to look at treatment options. At that time, the only treatment you could have is if you were admitted to a nursing home. There wasn't any other special care facility for patients with Alzheimer's disease. So they started this experimental project, and there were 12 assisted care living facilities for the treatment of Alzheimer's disease. And at each of those, a nurse practitioner would visit each day, and they had non-skilled, non-nursing personnel who would have special training to take care of patients with Alzheimer's disease. So we did that for 5 years. There were 12 of them. I was working as a nurse practitioner in 10 of those. The university had 2 of those nursing homes that they sponsored. And then I also worked for the Elderly Advocate, which had another 8. So we were seeing all but 2 of those centers. Now, at the same time, the U of A was doing some research on programs with residents and non-residents, and when I read the report, I noticed that they didn't write anything about those that had nurse practitioners or not, that they didn't consider that as a factor. So we did some research of our own to see what do nurse practitioners do when they make rounds. So in addition to looking at the patients to see if they have any illness or need treatment, we also spend a lot of time with the families and staff and teaching and education of how to manage these special conditions. And so I'm still doing research in that area, and I'm still doing treatment of patients. I make rounds in the morning before I come to teach. Also work on, 1 day or more with patients with Alzheimer's disease, in addition to working on research with children with asthma. So some people say, well, how can you do children one day and patients with Alzheimer's the next day? And I said, it's not that difficult because they both are very special populations. They both need an advocate, and they both can't tell you exactly what's wrong with them. They need a lot of observation and skill in the management and care. So I think that working with children and patients with Alzheimer's disease has given me that special feel for what can I do to communicate with people sometimes who've lost other avenues of communication. But I'll talk a little bit about that in a moment, what we're doing right now. And we're passing out some of my slides here about the background and the history of Alzheimer's disease. But the Alzheimer's Association here in Arizona has been very active in doing a number of projects, and that one is with special, what we call the Alzheimer model. And so we're still doing that at a lot of care centers. Scientists estimate that up to 4 million people currently suffer with the disease, and that there's 368,000 new cases every year, because the major risk factor for contracting Alzheimer's disease is age. So that's why you and I and most people are interested in what is Alzheimer's disease, will I be getting Alzheimer's disease, what can I do to prevent Alzheimer's disease? And we don't have a lot of knowledge in that yet. We're still working on that, but I can tell you some of the things that we know make a difference. Now, how do we find those things out? Because we don't have a definite test for Alzheimer's disease. Sometimes it's not diagnosed except upon autopsy is what we consider the final way of finding out. We have gained some of this knowledge from the twin studies that were done at NIH on identical twins. And they followed identical twins, and they found that some of them developed Alzheimer's disease and some didn't, which was very unusual, because if it's genetic, if it's hereditary, if they're identical twin, they both should have it. So they looked at those factors, and we'll talk about some of those in a few minutes. What was the difference between those twins and why they might not have developed Alzheimer's disease? And it was based upon diet and some other things. So it's not definite, but we know those are associated with decreased risk of Alzheimer's disease. In the normal person, we go through subtle age-associated changes in the rate at which we can absorb and learn new information, and the rate that we store it, and our ability to adjust to changing demands and to respond to new cognitive challenges. And so for many of us, we say, oh, I can't remember this, I can't remember that. Is this a sign of Alzheimer's disease? Probably not. Many researchers are doing studies on memory loss, and not only in this country but other countries. And in Denmark, they found that of about several thousand people that they studied for memory loss, only about 47% had Alzheimer's disease. The others had other conditions that were contributing to their memory loss, which may or may not be treatable, but a lot of things are treatable. And so if you look on page 2, I sort of made a bold slide there for you to see on the treatable causes of memory problems. So anytime someone would come to my office or to the physician's office and they say, I think I might be having problems, I might be having some memory loss, or a family member is having memory loss, we would first look to rule out any other possible reasons for this. Because in this Danish study of the patients they did, a lot of them were reversible causes of memory loss. In our modern day society, we find that medication is the #1 reason for changes in memory. And so I put in some little questions here, which I won't go into right now, but you can take later, on medication tests. And then we know that alcohol, depression, tumors, problems with heart, lungs, or blood vessels, metabolic disorders such as thyroid, head injuries, infections, acute medical problems, and vision and hearing problems all contribute to problems with memory, and a lot of these are treatable or adjustable with the medications. But drug reactions tend to be the most common cause of the treatable symptoms. So in the medication test, part 1, you'll see here I've had match the following drugs with the most common side effects. And the side effects are slurred speech, dizziness, abnormal bruising, and you can look at the medications. In the second, part 2, we have confusion, hallucinations, dry mouth, drowsiness, low blood pressure, and decreased coordination. And then you're to match those with which drugs cause those. Then I have the answers there for you. And we talk about what sleeping pills do. Diuretics is a commonly prescribed medication for a number of diseases, including heart and blood pressure, but it can cause confusion, weakness, drowsiness, restlessness, muscle cramps, muscular fatigue, low blood pressure, nausea, vomiting, slow pulse, stomach upset. And so any persons that are prescribed those need to be careful of those symptoms, that they can contribute to other problems. And a number of people are on antidepressants, such as Prozac, Paxil, Sinequan, and those also can cause decreased appetite, constipation, tremors, and sometimes affect memory. Digitalis or digoxin or lanoxin, which is frequently prescribed for heart disease, can cause memory loss, personality changes, agitation, hallucinations, nightmares, and depression. And so that has to be regulated. Now, some people get on heart medications and don't go to their doctor for follow-up to have the blood test to make sure that the blood is not having an overdose effect. So I do find that frequently people have not gone for a couple of years and maybe they are really getting too much of the medication, because depending upon how much fluid you take, on your diet, you absorb and retain this over a long period of time. It doesn't leave your body every day in 24 hours. A certain amount stays there, and then you take another pill, and then a part of that stays in your system for quite some time. So a lot of drugs do have what we call the long half-life. They do not leave your body in 24 hours. So as you take daily medications, you could get overdose, and depending on your physical well-being. So this is one of the things that we do as nurse practitioners, is monitor patients on medications and look at the effects of medications. And even when they're in treatment, many times people will have reactions to medications, and they'll say, well, how can you tell, since they're already confused, they're already having some problems with memory, how can I tell if it's due to medications? And so any change in their behavior is a clue to me. And most patients, once they're admitted, they don't die of Alzheimer's disease. They're going to die of urinary tract infection, or they're going to die of pneumonia. So part of what we do as nurse practitioners do early detection and treatment of these common diseases so that we can improve the quality of life and have independence sustained as long as possible. Now, I've had nurses at the college say to me, oh, Evelyn, I wish that you were the one treating my mother, because my mother fell, was admitted to the hospital, had a broken hip, and it was all due to a urinary tract infection. And then she didn't recover, and then she had a stroke. And if they had found that urinary tract infection early enough, then she might not have had that kind of sequence of events. So this is some of the things in older persons who are in nursing homes or even at home, that the symptoms of urinary tract infection are very subtle at first. And as I'm going through the centers where I work, I look for any slight change in that person's behavior, and that's what I try to teach caregivers and family members who are maintaining their persons at home, that you look for those subtle changes. They didn't eat, and they usually love to eat. They didn't sleep well, or they seem more nervous, more agitated. It could be a sign of infection. Okay, the only two definite factors that increase the risk for Alzheimer's disease are family history of dementia and Down syndrome. So persons with Down syndrome have a higher chance of getting Alzheimer's disease. Of course, we didn't know that for quite a few years because they didn't live that long. And now I have a nephew who has Down syndrome, and he'll probably lived longer than his mother, So he's in very excellent health. She takes very good care of him. But relatives of persons with Down syndrome also could be at higher risk. They're not sure of that association yet. Okay, and then we said, well, don't we have any diagnostic tests? We're doing all this research. We do have a study of looking at one of the genes that may be a factor, but you could have that gene and have Alzheimer's disease, or you could have it and not have Alzheimer's disease. So that's why we don't do massive screening, because it's not definitive. It's not like definite that you're going to develop Alzheimer's disease if you have that gene. Okay, the two things that on the first page talk about what are the two characteristics if you're looking at the brains of persons with Alzheimer's disease. And I'm not into that research, but we have a lot of researchers in Arizona that are doing that. And on Channel 8 a couple of weeks ago, they showed some really interesting research, and they were looking at the plaques in the neurofibrillary tangles. And they're not sure if those cause the Alzheimer's disease or they're just part of the characteristics of the disease, but they have in experiments reversed some of the changes with Alzheimer's disease in animal studies by dissolving some of those tangles and the medications that they're using in this particular research, and I'm not an expert on that, and I can't tell you all the details, but since it was on Channel 8, you might want to get a copy of that sometime to look at, is that they were dissolving some of those tangles with drugs that they use for heart disease and other types of medications that we currently have, angiotensins. So I thought that was extremely exciting because up to now, we have had nothing that could reverse Alzheimer's disease once it's diagnosed. We've had nothing that could change the outcome of the course of Alzheimer's disease. We can only delay the symptoms, some of the more severe symptoms, and we can do more to increase their everyday health and quality of life. So what I do, the goal in mild to moderate stages is to maintain normal functions in a safe environment, and that's where I work. But prior to that, what I wanted to say was there are things that we know are associated with Alzheimer's disease and possible things that we look at. So if they come into the office, we find out most of our information from the family. And in the interview, we would ask, how long have they had the symptoms? If it's something that came on very suddenly, I'm going to look for an acute illness, medication problem, rather than being Alzheimer's disease. Have the symptoms progressed over a period of time? What other conditions do they have? What medications are they on? Do they live alone? Do they live with others? All of those have impact on the diagnosis. And then after we've done a complete history, we'll do a complete physical exam, we'll do laboratory tests. Now they have some MRI imaging studies that are more accurately can see some of the plaques or see symptoms in the brain that look like they might have the plaques. We'll look at the functional status of the person, how well they can do their own care. And then last, we'll look at the mental status. But that's after we ruled out everything else. Some people think, well, that's how they diagnose Alzheimer's disease, just with that many mental exam. No, we don't. We do the complete physical to rule out all possible reasons for any other organic diseases that could be treated. But we know that in Alzheimer's disease, there are three areas that persons have problems with. One is in orientation and spatial ability. Do they have trouble driving or finding their way around familiar places? Language, do they have trouble finding the words to express what they want to say? And behavior, do they have trouble paying attention? Those are some of the symptoms that family members might report to us. In fact, one of my own dear friends who was a teacher for many years in Washington, D.C. called me one day and said, I think I have Alzheimer's disease. I got lost driving to the post office. Now, you have to remember, she grew up in this town. She taught all the elementary school students in this small town in Virginia. And one day, going to the post office, which she had done 100 times in 80 years, she got lost and couldn't find her way home. And sure enough, she did have Alzheimer's disease. And so she diagnosed herself and went to the doctor and said, how could I lose my way driving in the familiar route that I go all the time? And she then died of Alzheimer's disease within 3 or 4 years after that. Most people have very subtle symptoms for a period of 2 years before the family members notice, 2 to 3 years, and they live approximately 10 years after they're diagnosed. So it's not something usually, but it's different for each person, each family. Now, some people have personality changes, and the families notice those first. They might become passive, hostile, stubborn, suspicious. They might also be depressed, because if you think that you have something that's going to be life-threatening, that's going to alter your quality of life, that's going to cause you to lose precious memories of your family and your life, you would become very depressed. So in the early stages when persons are first diagnosed, depression is something we have to treat at the same time. So we asked in the beginning, do you have trouble remembering new information? That's common with everyone that's older, but as it becomes progressive, where they forget whole conversations, they forget appointments, they forget where they put things, not just 1 or 2 times, but all the time. They have difficulty in balancing their checkbooks, that mathematical computation of organization. So that's some of the things we look for. Now, I also do other research with caregivers or persons that are taking care of their family members at home who do not have Alzheimer's disease. And in the beginning, I remember on my computer disk, I only allowed 2 spaces for the age of the person and the caregiver. And I had a person who was 104 called me, and said, I'd like to volunteer my daughter to be in the study rather than the daughter volunteering the mother to be in the study because she thought her daughter needed help. Now I went there and the mother was 104 and she was very happy. She was changing channels and doing her everyday activities, and it was a daughter who was very depressed and unhappy because she had come to help mother and now her life had changed. But her mother's life was great, you know, and she was doing well. She had no memory loss at all, and of course at 104 she had no risk factors for heart disease or Alzheimer's or anything. So, but her daughter must have had about 25 problems of illnesses and medical problems, diabetes, stress, you know, heart disease. So she was having a lot of problems. And then I visited another gentleman in Tucson Senior Center. He was very upset because he was 95 and his son, I guess, was 78, and he had told his father, I'm taking away your checkbook, you're balancing things incorrectly. They were both CPAs. And he was very annoyed with his son. He said, I just had one calculation wrong, and he decided I can't balance the checkbook anymore. But with Alzheimer's disease, this is much more pronounced, not just something that comes with aging. Their family members very often don't know that they haven't balanced their checkbook in years, and they've just counted on the bank statement being correct, and they have no clue. And so it's very subtle in the beginning. After we've done all that diagnostic work of it, we can find no organic cause for the problem, no diseases, no medication interactions. Then we do the mini mental exams, and I have some of those kind of questions, and I think you've seen those before, but those are similar to what we're asking there. So we'll ask things like, what is the date today? Who is the President of the United States? Who was the President before him? And you might have to think twice on that. And then, but that's pretty livid in our memories. And then we ask, what floor do you live on? What's your address? And I showed the students a videotape of an elder person doing this at a nursing home facility. And when you're watching the tape, you think that she's doing everything perfect, and she probably doesn't have Alzheimer's disease. Because she said, oh, I live here in such and such county, I'm on the second floor. She answered everything very quickly, very articulate. Well, if you didn't know, you would think she was okay, but the actual fact was that wasn't the state she lived in. It was the state she was born in that she answered. And she didn't live on the second floor, she lived on the first floor, and she didn't live in that county. And so if you didn't know, just watching the tape, it looked perfectly normal. So you can't tell just by watching. You have to know what the answers really are. Then we have other questions like count backwards, subtracting 3 from 100. Or we say spell world backwards. And then we ask them a question. Now, they did this to me on the telephone when I was applying for long-term care insurance. She said, okay, now I'm going to give you this list of, usually we give them a list of 3 things. And then in 3 or 4 minutes, we ask them, give me those 3 things back. So this lady on the phone gave me a list of like 25 things. Then she asked me, would I go to the telephone book, look up my doctor's office phone number for her, and then go look up some other phone number for her, and about 15 minutes later asked me to name those 20 things. So I said, Jerry, this isn't how you do the test, but I'll do my best. But you don't wait that many minutes and ask them to do 29 things in between. But we usually wait 3 or 4 minutes. We ask them a couple questions in between. Now, one day at one of our units where we treat patients with Alzheimer's disease, the way we monitor how the medication is doing is that we repeat the test every 6 weeks to 2 months. And so I was doing the test at this one particular facility where the patients are quite advanced, but you don't always lose your sense of humor. So I said rose, and the patient said garden. And I said orange, and they said tree or something, and I'm thinking, I said, no, just repeat the 3 words, and then I'm going to ask for it again. So every time I'd ask them to repeat them, they'd say opposite word, and everyone was laughing except for me, and I'm trying to be serious and do this test and get it right and give them the benefit. Finally, everybody said, oh, and they're playing word association with you. They're playing the game like on TV, and so you're the only one not getting it. So there's other times when I've come into the unit, and I remember this one patient very distinctly. She said to me, okay, what is my name? I'm not too good at remembering names. It takes me the whole semester to remember my student's name. When they're finishing is when I know their name just about. So I wasn't sure, so I tried to think really hard. She said, no, that's not it. And I want you to remember this. So she gave me her first, her last name, her age, everything. And every day when I would come, she'd say, do you have my name ready yet? Do you know what it is? And I'd say, yes, I do. And then after a couple of years of treating her, one day I came and she was in tears and she said to me, I can't remember the names of my own grandchildren. And so that's the sadness, that's the heartbreak of Alzheimer's disease, because you're aware of it, you know you're losing that, and those are such precious memories. But then I have family members who say to me, well, should we take them off the medication? Now, the medications that we use for Alzheimer's disease reduce the more severe symptoms or delay the onset of the more severe symptoms, and they can keep what we call the mini mental status exam, or how their memory is, higher. So we use that test initially for diagnosis and also see how they're doing on the medication. So if you look in the research literature, you'll see that there are a number of medications they're testing, such as Aricept, which is most commonly known, and it doesn't stop or reverse the progression of Alzheimer's disease. It appears to help only some patients for a period of time ranging from months to 2 years. That's what it says in the literature. However, in real practice, I can tell you that we can't abruptly take them off of that. So even though the drug is expensive and people say to me, well, now that my mother seems to not remember me, shouldn't we just stop the medication? And I say no, because it seems to have some benefit in their overall health. Because I've had in other patients where, as they got to later stages, family members said, let's just take them off because this stuff costs so much per month. And when I've taken them off, they've had a rapid decline in both their physical and mental health. And if I try to put them back on the medication, they don't recover where they were. So many of us who have been working with the Alzheimer model since 1994, we have found that just in our own everyday practice, and that's not necessarily in the literature. And that's why I say in nursing, we look at the effect of treatments on the patient and on the families. And most people want their family member to have quality of life, to be independent, to enjoy everyday activities as long as possible. And so I have found if I've taken them off the Aricept, and I'm not a specialist in the biochemical workings of that drug, that even though it says that it may only be effective for 2 years, we find that it really does maintain them at a higher level, a better quality of life, and more functioning in just our everyday experience with the drug. Now, other drugs that have come out that are similar to this are Exelon and galantamine, which I think is called Remelin. And what we do to test those is to look at where are they on the mini mental status exams. And I have this all in the slides, which you can read later. It might be jumping around here, but you can look at these over sometime. And we know that those medications increase the acetylcholine level in the brain, but there's newer meds coming out now that affect different parts of the brain, and I can't explain to you exactly what they're doing. There's that new treatment that they're thinking of that's going to maybe dissolve some of those tangles, get rid of the plaques. They're testing that in animal studies. So instead of just increasing this one chemical in the brain that's associated with Alzheimer's disease, there's all sorts of other research that's being done. But what we do is we're measuring that mini mental status, every 6 weeks to see are they staying the same, hopefully, and not declining. And that's what all of those drugs are looking at. So as an NP, I monitor the patient's reactions to their treatment. I keep the patient as active as possible. I educate the family and the caregivers. And I help in the behavior management of patients with severe agitation and sleep problems with Alzheimer's disease. Now, there are many forms of it. At some of the places, persons have a lot of problems with wandering and agitation, and that they can't stop walking. They might walk in circles. So you'll see that we have many, many assisted living facilities in Arizona compared to other states. And we set up those units so that they can live in a house-like environment. These are the best ones, I feel, for Alzheimer's disease. If you're looking for care for a person later on that's a member of your family, look for the ones that have individual cottages rather than just one big, hospital-type institution setting. Because I find they do the best in those kind of environments where there's like 10 people in one house-like situation. They eat their meals in the dining room. They have the same caregivers. They're able to go outside, and most of them have fenced-in areas where they can walk around circular paths, find their way back to their own house, and they learn the people in their house, they learn the activities, and I find that they do much better in that kind of smaller setting. Even though there could be 7 or 8 of these cottages on one grounds, it's better than just one big long hallway with doors. And so that's kind of areas that I have most of my patients in. And then I go from cottage to cottage, and people say, well, I don't know if I should visit my mother anymore. Does she really recognize me? And I said, I think she knows you're a family member. She knows that you're someone special to her. She may not remember exactly what your relationship is, but because they see me more often sometimes than family members, I sometimes wonder too, do they know who I am? They know who I am the moment I walk in the door. They know that I'm there and what my capacity is, even if they haven't spoken a word in a year. And one time I went away on vacation for a little longer than usual, and I had a colleague of mine, substitute, who has a totally different personality than I do. And when I walked into the unit, which was my most severe level of patients who cannot speak at all, 3 of them raced over there, grabbed me, started crying and hugging me. They thought I'd left. And so they really recognized that someone different than me had been seeing them. It wasn't all like me. And I said, gee, I should leave more often, because you don't always know when you're taking care of patients who can't communicate if they really notice you, or if they know who you are, if they recognize. But many times the people within those units should say, well, what kind of quality of life is this? They form bonds within those cottages. They make friendships. And very often they'll have the same personality and the same problems that they've had all their life, or they'll have the same enjoyment that they've had all their life. So I've had caregivers say to me, well, I think Mrs. So-and-so needs medication. And so then I will talk with the family and say, now, how was your mother when she was younger? Did she have this kind of problem or that kind of problem? Because staff seems to be concerned. And this is very important, because I remember we had one person who was especially difficult for the staff to manage. And when I talked to the family, they said, well, that's how Mother's always been, you know. And so I cannot medicate away personality. So she had been a very important CEO and managing many people in her life, and so she decided to manage the whole staff there. But they weren't real happy about that. But, you know, medication wasn't going to help them. But what I'm really concerned about is that we maintain people at the best quality of life, and that they have the best level of independence. And so putting people on medications because they're wandering around or because they're not sleeping is not the answer. So I and my colleagues have been doing some other things. And especially when we see people transferred to us from other facilities where their solution has been just put them on lots of high doses of medication to control their behavior, to make them more relaxed. And what it usually ends up is they don't eat then, or they fall because they don't have good balance, and then they're going to break a hip, and they're going to be in a nursing home. And the worst quality of life is to be a bed patient. And most persons with Alzheimer's disease are physically very healthy, or they only have the illnesses that are managed, such as heart disease or stroke. But by the time you get Alzheimer's disease, you're over 60 or over 70 or over 80, so you would have had to be in pretty good physical condition. And so what I want to do is keep their quality of life as good as possible. And one of the things we've tried is aromatherapy. Now, if you look just in the medical research, you'll see that people from JAMA will say, well, how could aromatherapy work? Because some of the centers that are destroyed in Alzheimer's disease affect the smell centers, olfactory nerve centers. Well, I'm not sure how it works, except that you may not have to be able to tell what an orange is from a lime for it to work. And it doesn't work on all patients, but I did some. We sent notes out to the family members, said we'd like to try this and try reducing medication for agitation and see if we can get better control. And those that wanted to participate, we got their signed statements, and we tried now, I would say, between 12 and 15 patients. I don't keep a lot of track of it, because sometimes they'll call me at 5 in the morning and say the new patient was admitted and they have not gone to sleep yet, and it's been 29 hours. Could you come over here right away? Could you order something? And I said, well, let me bring over the aromatherapy. Oh no, we need a drug, we need a pill, we want something to knock them out. I said, no, let's try this first. So we had a new admission just recently, and I hadn't used the aromatherapy for a while, so I ran over there at 5 in the morning. So, okay, now just put this on their wrist. They're saying, how is this going to work? Well, by the time breakfast came, the person was sitting down for the first time in 3 days since they were admitted. ate their meals, and went to sleep at 8 that night and slept all through the night. So I said to another colleague of mine who's a psychiatric nurse practitioner, well, how will I know if it's really the aromatherapy, because I'm trying to do this for a regular research paper, or did they just pass out from exhaustion? Okay. He said, well, people that are, passing out from exhaustion, from agitation, usually do not rest well, do not have a relaxed sleep, and the next day are just as agitated as ever when they wake up. This person now, since we started the aromatherapy, and they came in with medication for relaxation 3 times a day, now is going to sleep at 8:30 and sleeping till 6 in the morning, which they had not done for several years, and is sitting down to eat meals, which they hadn't done, and was having visitors, which they had not done for a while. Now, I had another person who was very physically active, had Alzheimer's disease at a young age, I would say young when they're in their early 60s, and would love to go outside and walk around with her jogging outfit on, but she was on medication because she was very aggressive and agitated, and at other facilities had struck other patients. So the medication to control that behavior made it impossible for her to run or walk without some assistance because she was not steady, and we didn't want her to break a leg. So the doctor at this facility, he is a geriatric specialist, he believes in reducing medication to the minimum amount. We tried reducing medication, but each time she would get really agitated, couldn't sleep, pacing for hours. So I said, well, would you mind, now usually the physician will be last to try some of the newer ones. I said, could we try the aromatherapy while you're reducing medicine and see if we can get her down to a lower level? So he, for the first time, wrote an order saying, let the patient try the aromatherapy with the NP protocol. We put her on the aromatherapy, and within a week, we had her off all the medications, and her family was happy because she was able to walk outside by herself, in the control ground, in and out as much as she wanted, and being able to do that activity without any risk of falling, having perfectly good balance. She was very calm after that. And what I find in my follow-up visits after 3 months is to look to see, do I have to put them back on medication? Is it not working? Most of the staff say that after a while they don't need the aromatherapy or the medication. So I don't know if it just helps with that transition, but for many of them they were agitated for a number of months or a year before they came to our facility. But I know that it does work on quite a few, especially those that pace a lot, that have a lot of agitation due to not being able to sit still. It doesn't work on everyone because there's so many different facets of Alzheimer's disease of how the person's affected. It doesn't work on persons who, which can be very annoying to staff, but persons who say, like stroke patients, words that don't mean anything hour after hour and keep saying the same word over and over. It doesn't work to stop that behavior. We've tried that. But it does work for people who pace or can't sleep. So I would say out of the 15, I had 13 that had very positive responses, that they were able to reduce their medication to the very minimum or none. And then I had 3 or 4 that didn't affect them one way or the other. But the nice thing about adding the aromatherapy as a complementary therapy is that it doesn't have any side effects. So someone said, well, did you use a special one? Did you have it specially made just for Alzheimer's patients? No, we didn't. We used one that was called Tranquility for Sleep, and we used one that's called, I think, something like Soothing for Relaxation. And then we had another one called Invigorating for persons who were depressed and didn't react to the regular medications. But so far the Soothing one has been the best one. The Tranquility has such a terrible smell that the staff hated putting it on the patient, plus they said it made them sleepy but not the patient. And the Soothing one seems to relax them more. Now, the Invigorating I've only used once because most persons with Alzheimer's disease are not no activity. There are some, but we use regular antidepressant drugs on them with great success. But we had one person who had a reaction to medications and couldn't take the antidepressants, didn't want to participate in anything, wanted to stay in their bed, didn't want to eat. And we used the Invigorating. Within 2 days, they were up in the dining room participating in activities. That was the only medication they were on because they had reactions to others. And eating their meals in the dining room, and after a few weeks, we didn't have to give them the Invigorating. So it did something to stimulate some center. As I said, I'm not the biochemical researcher, I'm just looking at the effects of treatments on the patients. And so far, I've seen no side effects and positive effects for many of the patients, not 100%, but for many. So that's where I'm continuing to do some work. We've also tried like music therapy, pet therapy, all different things that improve the quality of life for the persons. But not everybody responds to that. I've had persons that when I said they're going for music, they're saying, like this, hands up, forget it, no, And so, we don't force anyone to do something they don't want to. At some of the facilities that had a religious background, we have whole cottages where there's just nothing but priests, and they're doing the rosary every hour, and they forget when they started, so it's continuous 24 hours. But that was something they did before. But some of the things then for prevention, that's what people want to know, well, what can I do for prevention? If you look on the last page, some of the same things we do to maintain function, we think also work for prevention. But in the literature, you will see that higher education is associated with decreased risk. Mental stimulation is associated with decreased risk. Doing things like crossword puzzles, participating in learning new things, socializing with others, hobbies, and reading. And so I brought you a couple of the new research articles that were on the internet, and you can use that website to learn more. But it says use it or lose it. Study shows mentally stimulating activities may reduce Alzheimer's risk. That was February 2002. And of course you've seen this, and they're just talking about the research that's been done in that area. And then we know that certain elements in the diet, vitamin E is associated with decreased risk for Alzheimer's disease. Also, now they're thinking that there's an association with folic acid. That just came out in March 2002, so I attached that for you to read at your leisure. Low-fat diet, estrogen replacement in women, and the use of non-steroid anti-inflammatory drugs like Advil, ibuprofen. Now, those particular ones are associated by looking at those twin studies where there were identical twins, one got Alzheimer's disease and one didn't. And that was also on Channel 8, where they showed these two sisters, and the one had injured her arm or leg or something and took ibuprofen for a number of years for pain, and she didn't have the Alzheimer's disease and her sister did. So they think by looking at these, who gets it, who doesn't, that those use of anti-inflammatory drugs have something to do with it. We know that those plaques and those tangles in the brain cause an inflammation of the brain. So there are other researchers now who are looking at how do you reduce that inflammation. And because they've seen this association that persons are less likely to have Alzheimer's disease that have been on treatment for back injury or something else or arthritis and used anti-inflammatory drugs. And so they're doing research with stronger type of anti-inflammatory drugs to see if that can reduce some of the symptoms of Alzheimer's disease. But right now the major drugs we're using, the Aricept, the Exelon, the Ritalin, are not reducing the inflammation. They are also just increasing this one chemical factor in the brain that we think is associated with Alzheimer's disease that they have a deficiency of. And it does keep their mini mental status level higher while they're on it. They do increase above the borderline, like let's say they weren't diagnosed till maybe the third year of symptoms. They will go up and then they'll maintain for a longer period of time. But the outcome of the disease or how many years they live with the disease isn't changed by that drug. But with all this new, every month there's new things published. Unfortunately, just a couple of weeks ago it was published about the vaccine. And I was looking forward to seeing the outcomes of that research. It was the first human trial of the vaccine. And I think you saw in the newspaper about the subjects became very, very ill. I'm sure that they will be working on that, looking to see what was the factor that caused that. But that's some of the newest thing is the vaccine for Alzheimer's disease. But right now we don't have some real positive news that that's anywhere near being ready. So there's many things happening, and since I'm not involved directly in that aspect, my aspect is looking at what can I do to help families and persons who already have the disease and make their life as high quality as possible. So if you have any questions now, I'll be happy to answer.
Does everybody's memory fail to a certain degree as they age?
No, I find that some people's memory is a lot better than mine when I'm in the classroom. And so everybody is different. I think on that first page where I talked about what is normal aging, what happens in the normal aging brain, and with Alzheimer's disease, it's that plaques in those neurofibrils area, things that develop that are different that you don't get completely in normal aging brain. But no, we have all different levels of what people can remember and retain, but we think that being mentally active helps you to retain that longer. So, but forcing yourself to do more than the everyday thing. That's why I hate doing crossword puzzles, but my friend who is 20 years older than me and in much better shape than me says, do crossword puzzles, do crossword puzzles. So on the recent trip on the airplane, she brought me a book to do crossword puzzles. And so I do lots of mentally challenging things every day. Just working at the university can be a mental challenge, getting there through the traffic. But see, I'm used to that, and I read tons of books every day. So I think it's pushing yourself to do a little bit more, to learn new things, to take new challenges. So you can't just do the same crossword book that you've always done. It's got to be a newer, harder one. Yes.
Now that you have an extensive experience with aromatherapy, have you noticed any behavioral changes in yourself depending on what flavor of perfume you're wearing?
Well, because so many people are allergic these days, I try not to wear any that's going to be offensive because I work with people that have allergies. Because with asthma, perfumes will trigger allergic reaction, and we think that's the main thing that happens with asthma is that people have severe allergies. So for my other patients, I avoid that. But, I do find that the staff start to be a little nicer too when I have 4 patients on aromatherapy. I'm the soothing one. Yes.
Have there been any double-blind studies with the aromatherapy?
I would like to do that, but unfortunately I haven't got the funding yet, but I've been writing a small research grant to get that. I had a small grant just to buy the therapy, and since it doesn't seem to have any negative side effects, I've used that just to supply it free to the families and the patients who want to participate at the 2 centers. And so I am working on writing for a larger grant to maybe do that kind of a study. Yes.
When a person dies of Alzheimer's disease, is that the immediate cause, or are there other related physical symptoms which cause the death?
Well, in the patients that I've taken care of, I find that if we can prevent them from having urinary tract infections and pneumonia or treated as soon as possible, they will live for quite some time. When we first did the assisted living study, we were thinking that they would just be there for a couple of years, and then they started getting older and the families didn't want to move them. And 3 and 4 and 5 years later, they're still at the assisted living facility, still in great health because the nurse practitioner came every day, and this moment you coughed, I was listening to your lung and you got the medicine if you needed it. So I've had families come to me saying, well, we didn't think Mother would live this long. It's been 10 years. So with good medical treatment, they can live quite a long life. However, it does seem like it happens all at once. If they're truly going to die of Alzheimer's disease, to 2 or 3 patients that I've seen that died of that, they suddenly, no matter what we did, started to lose weight, even though they were eating well every day. I took them to the physician. We did different tests. So I thought maybe something had happened with their heart. They just seemed to be more tired. And this all started a couple of months before. And no matter what I did to intervene, we checked everything. They didn't have infection. They didn't have any other problems. They were eating well, but they kept losing weight. And pretty soon they just got really fatigued and tired, and then they didn't want to get out of bed. And then they just died. So of 2 or 3 that I've had to the very end like that, it seems that all of a sudden they just have a decline, even if they're physically free of every kind of disease, or they're going to die from complications of something else they have. If they have heart disease, they might have a heart attack, they might have a stroke. But a while back, several years ago, before we knew a lot about Alzheimer's disease, many patients died because of urinary tract infections and pneumonia. And there were even physicians who believed that maybe that was a better way to let them go and didn't want to treat them for that. But when I'm working with my patients, that's my philosophy, is to keep them as healthy and happy and have as good quality of life, which to me means being able to function independently as long as possible. Because nothing's worse than to be dying in a nursing home bed.
How
Well, if they're at home, they could put it on a diffuser, but what we did, because we didn't know how it would affect other patients, is that we have it in a, it's kind of like an ointment bottle, we put it on the wrist just twice a day in the morning and at night, or once a day if it's for sleep.
Does everyone else around them sniff that?
No, usually it's just on their wrist, so like when they're eating, they smell it. You know, it's not that strong, but we found that was a way to keep it just for that patient. Yes.
My mother's sister had, I don't know if she died of Alzheimer's, she had Alzheimer's anyway, and the long stories about she didn't know who I was and so on. But my question is, given that it occurs in your family, as opposed to no evidence that it occurs in your family, what difference does that make in the probability that you'll get it?
Well, the two main risk factors are age. As we get older, we're all at higher risk. And the second one is family history. And then Down syndrome. Those are only three things that are definitely associated with you getting it. So if I had family member, and I felt like, you know, I would be at high risk, I would look at that prevention list and take the vitamin E, take Advil, do my crossword puzzles, which I hate. But, you know, every once in a while when I start forgetting how, you know, it's taking me longer and longer to remember 50 students and what their names are, and I get confused. I'm thinking, like, I think I'm getting it even though I'm doing all this mental activity. But sometimes I think in our modern world that some of the loss of memory is due to stress when you're trying to remember too many things at once and you have too many agenda items and too much to do on your to-do list. You will start to, stop remembering things, because when I'm away from the college on vacation, I can remember my whole list real easy. But so I really think that sometimes we have to look at what is our usual lifestyle and how much stress level do we have, and that might be contributing to your memory loss.
So you're saying there really isn't much of a correlation, and given that it's been in your family, is that what I heard? Or?
No, there is a correlation, but it's not a definite, because even if we do this one test we have to see if you have that particular factor on your gene, doesn't mean you'll definitely get Alzheimer's disease, but you're at higher risk. So higher risk means you're more likely than someone who doesn't have a family member, and that percentage is not like a definite percentage. You can be 10% higher, 15% higher risk. But then you might also, have some other diseases that you're at higher risk to suffer from than Alzheimer's disease. Let's see, way in the back there. All right, you can be next.
The incidence of Alzheimer's, has increased, or do you know?
I think it's just we've had more people live longer, plus we have better ways now of determining what it is. There are other kinds of dementias that aren't Alzheimer's disease, but at least 60 to 80%. Now, if you look at statistics, they always give you this range, which is quite off. 60 to 80% of all dementias are Alzheimer's disease. What are the other dementias? You can have other dementias that look like Alzheimer's disease that are due to blood vessel breaking in your brain, stroke symptoms, heart deficient blood syndrome, we call that vascular dementia, where you're not getting enough blood flow to the brain for various reasons. Then there's different diseases that are hereditary diseases that cause dementia-like symptoms. And some of those you've read about in the news. They have these long names, Jacob Creutzfeldt and all that different things. So there's all these hereditary diseases that before we didn't diagnose and differentiate from dementias. So those are maybe 10%. And, the vascular ones are maybe 20%. But the vast majority, 60 to 75%, we're going to say is due to Alzheimer's disease. But there are other types of dementias. And way back there.
Yeah, I had read that there are different markers, genetic markers. And I had read that for Alzheimer's, if you had 9 digits with a closed circle, then you would almost certainly get Alzheimer's. Do you know anything about that?
I think I put that on the page 1 there about that, or maybe it's page 2 that I put about the research on that for determining that. Let me see what page did I put that on. Yeah, on page 3. And that is talking about that genetic marker located on chromosome 19 are at increased risk for developing Alzheimer's disease. However, testing for that doesn't mean that you would definitely get it. So we don't do it in the general population because you could have that marker on that gene 19 and not get Alzheimer's disease. Okay, well, I guess I'll have to ask you all since you invited me. What's your question?
No requirement. I wanted to know, this aromatherapy, where do you get this? Because you said you can put something on your wrist and it helps you sleep. I mean, there's no side effect.
Well, they do have stores that specialize that. We used an aromatherapist that is here in Scottsdale. She was giving the classes, and my colleague, Sharon Stern, who owns the Elderly Advocate, decided to go and participate in it. And of course, I, being from the university, am kind of hesitant to try new things. I told her, oh, I don't know if that's going to work or not. She said, well, let's just try it. So she went to the classes, she developed the protocol, and we read about it, you know, and I was kind of skeptical, I have to say. She was more enthused about it than I was, but of course I didn't go to the workshop. So I told her, okay, I'll try it, but we got to have a different protocol how we're going to do it. You know, come more from the scientific side, you know, and we're going to have to measure how we're doing it, exactly how much we're going to administer. We're going to have to write down what we did. So we developed this protocol and testing it so that we could be as rigorous as possible, only put it on their wrists, you know, only put a certain amount on, you know, and not trying anything else at the same time with it. But we do write down all those factors. It does work for some people. Now, they also use it at hospice to alleviate and help people to relax. And, you know, you see commercials on TV. The one we use is commercially prepared, and, you know, it has like 8 different herbs in it. So you can try that. We have had family members who said, well, I can't sleep now that my spouse is at the assisted living facility. We do other things too. We gave them the sound therapy where, you know, they listen to the soothing sound. They use the aromatherapy, they use the body pillow to kind of help them relax. And the person said it was so good, they went and bought another one of those, what do you call them, sound machines, so they could have stereo ocean sound on both sides of their ears, so when they turned, they didn't have to be trying to hear it. So they said it helped them sleep. I had another person at the university said for their mother who was ill and at home, you know, I tell her about these different things, and it did help her to rest, and she didn't have Alzheimer's disease. Yes, we know it does help some people, but not everybody responds to it. So you can try it. There are different ones. Unfortunately, I didn't bring that card. I'll have to ask Sharon, but I'll give it to you. I'll ask Sharon, who is the person we use that prepares the...
You go into Wild Oats to the vitamin...
Yeah, there are different potions of it. I think there are different strengths. This particular person that we went to the workshop for, we felt was very reputable, and I'd like to give her phone number to you, and you could pass it out to the members in your newsletter or whatever.
We have a talk on aromatherapy, and have someone, they do this once at Mensa. I don't know how many people would be interested in that.
Right, and because that's not my specialty, and we just let her put them together. But yes, you know, I do think it works, and I was very skeptical. But yes, there are specialists that just do that. Now, I'm not sure that, you know, it improves everything in your life, but for this particular situation, for sleep and for calming persons, we found it worked. Yes.
You stated that people who had Alzheimer's most likely had it in their family. Is that among...
There's a strong association of a higher risk if they had in their family, but no, a lot of the persons that I am taking care of, no one in their families ever had Alzheimer's disease, because of course all their family members are worried, will I get it too? But they don't have, if the mother's sister doesn't have it or anybody else in the family, it doesn't seem as strong a link, because obviously they don't do a lot of this testing on the genetic and on the brain tissue until the person dies. So there's a lot of things they don't know about until then. Yes?
Yeah, I find as I get older, first of all, things aren't as important to me, so I don't remember them. And also I get, you know, a little personal electronic device that remembers all my phone numbers and all this other stuff. You know, I don't use my memory as much as I used to, and I just become lazy. But I'm still interested in, you know, intellectual endeavors and all. So does one take the place of the other, or?
Well, I think that we have a lot more things to remember now. I just last week decided I was gonna give in and buy one of those Palm Pilots because I don't have just 10 phone numbers to remember anymore. I've got like 20, 40 for business, 50 for ASU, 60 for personal friends. I started making numerous categories. Now I probably won't remember what category they're in, because as I started putting all these phone numbers in that I had on various books and in different pieces of paper and on my computer, it's probably going to take up the whole 8 megabytes just for the address book, and I'll have to get an expander chip. I think we do have a lot more things to remember these days, that we're involved in a lot more activities than, say, my parents who lived in a small community and just had their address book contained just our family. They didn't have all these business contacts, speaker contacts, preceptors for my students' contacts, physicians who speak to our student contacts. I've got so many lists of people of phone numbers and addresses to remember even. So yeah, I think a lot of it is just how much we've expanded with the computer age, even though you resist it. I remember when I was about the last person that had a computer on their desk, but when I first went to NAU, what was that, in 92, she said, here's your office and here's your secretary, and the secretary was a computer. And, when you're up there in ice and snow and a little isolated, you learn fast, and now I'm the one that teaches everybody else at the college. Now, I was past 45 when I took that job, so you can really learn things at an older age, and so now I'm like the computer guru at our college. Everybody that breaks down and say, oh, we'll get Evelyn, she'll show you how to do that. Well, then the Palm Pilots came, and I thought, I really don't need that. I can remember this. But then last week I decided, well, I think I need one of those. But what I want to use it for is to collect data, because as I go to the Alzheimer places, and I want to look on the record to see how many treatments do they have, the aromatherapy, et cetera, I can enter those all into the Palm Pilot without carrying around pieces of paper. So they have expanded for research use. And also my students who are working in the doctor's office can put 5 textbooks into one little Palm Pilot. So one of my projects for my sabbatical this fall is to look at the uses of the Palm Pilot for student education and for research, because there's a lot of data I need to gather from my patients. And Mayo Hospital probably is one of the ones that has used a lot of technology in that they do all their charting by computers on the hospital floor, but they refuse to let the doctors have all this stuff in the clinic, whereas before they would let them have whatever they wanted. But there's some other universities where the residents and the physicians just stick their little Palm Pilot in the little machine as they walk in the door. All their patients' lab work and the histories, et cetera, are on there. They write their orders as they walk around. They stick it back in the computer, uploads everything, so it's all like paperless. So I'm going to visit a couple of those and expand what we do at the College of Nursing.
I think that's an interesting project to do. I just want to make a comment. In one of my former lives, I was a recreation therapist. My master's is from ASU and School of Public Programs, and data does exist on aromatherapy. Music therapy is all part of sensory stimulation.
Mm-hmm.
So if you need some numbers, and I have worked with Alzheimer's patients.
Well, here you got another speaker right back there. Yeah, well, the controversy for Alzheimer's use with aromatherapy is they felt that the olfactory centers were also being damaged, so how could it work? But I think because as you look at a whole different centers, and I work in like 10 different units, there are not 2 people that have the exact same symptoms. So, and maybe the 4 that it didn't work for out of the 15 I tried it with had some damage to their olfactory center enough that it didn't work. But since they can't communicate that well, I can't test it and say, well, what smell is this, or whatever that we use for testing the olfactory nerve. And of course, there are some sophisticated brainwave things that they could do, but I don't have funds for that being in the College of Nursing. Now, if I were in engineering, they have a few million more, but yeah.
Say the onset or the diagnosis comes at a certain date. Could 10 years earlier could there be any suggestions that the disease was in the future, in judgment and behavior?
I think that the earliest signs are because it affects those memory links of organization. So I think if you look at those things of what I had written on here, those are the questions that we ask. And family members in retrospect will say, well, I guess they had some of these symptoms a couple of years ago, but we weren't aware of it. Some people try to cover it up. They don't want to be less independent, and so they don't want to give in to any signs or symptoms or go to the doctor. A lot of people are like that about anything. I mean, they could have a tumor this size growing, but they're not going to the doctor to find out what it is because they expect the worst. So it depends on, I think I was talking with some people here, they said that their family members recognized they had symptoms and went immediately for treatment. If they can start an Aricept earlier on one of these drugs, they can delay some of that decline while they have the illness. And so some of my patients are talking and active, and I have all sorts of slides of the activities that we're doing with people with severe Alzheimer's disease. Others cannot talk at all, but they're still communicating, still actively participating. When I come, you know, they're doing all sorts of activities at these different units. So recreation and keeping them active is one of the things that calms them also, as you can let them know about that when you talk. Yeah, we do a lot of activities. Part of the Alzheimer model was that we would engage them in everyday activities. And the reason why we got the idea for the aromatherapy is we found that even if we weren't going to have coffee to drink because it was against their medical conditions, if we put the coffee pot on in the morning, people knew that it was morning, it was time to get up. And we didn't have to have alarms because they lose track of what day it is, what time it is. So we did those little cues as part of the treatment. And we would bake bread in the cottage, even though we weren't baking the whole meal there, the meal was being brought over from the kitchen, because that made them feel it was more at home and that there's good smells here, and it brought back what we call reminiscing therapy, that the smells can trigger happy events and pleasant feelings. And so they would bake cookies in the cottage even though they didn't do all the meals there. And that's why I like the cottage concept, because it's more of a home-like atmosphere. Now there's some people there that had a very busy lifestyle when they were younger, and they constantly are folding towels and doing the laundry. That's not how I plan to spend my retirement years, but some people, they can't sit down for a minute, so they get all the dishes and put them in the sink, or they want to wash them. We let them wash them, and then we put them in the dishwasher later. But they want to do laundry every day. Some are so neat, you know, that when I walk in, they take my bag and my coat and my stethoscope and put it away, and it takes me an hour to find out where they put it, because they don't know where they put it somewhere, you know. But because they don't like to have it just sitting there. I mean, I put down my little treatment bag and it's in the wrong place, it looks out of place to them, it's not supposed to be on the couch or the chair, and so it disappears. But, you know, I have like close-up glasses I use for doing part of the exam, and I am notorious for laying those down and forgetting where I put them. And it's pretty bad when you have to ask your Alzheimer patients what room are they in, and they know. So yeah, we try to keep it as happy and as stimulating as possible. And not everybody likes every activity. Now I said, when I get older, do not ask me to do that karaoke. You know, I'm putting that on my list of activities I know I will still hate, even if I have Alzheimer's disease. And I don't want to do crossword puzzles, you know. I've tried, I still don't like them.
Rita's husband has Alzheimer's, he's in the care center, and she says he's always wanting to help people, which can be a little bit difficult when he starts pushing people in wheelchairs around and the nurses don't want him to do that. So
Right.
do you have any suggestions about other activities you could do?
Well, we have them do different things, like at one of our centers, some of them go up and get the newspapers and deliver them to the different rooms of the people who still read the newspapers, because everybody's at different levels. Now, we've done a couple of different things. At some centers we thought it was better to keep each cottage separate and they all have the exact same activity level, and we found that wasn't really good. At another center we thought, well, we'll put all women in one cottage, all men in the other. I came in and there was like 5 black guys in a row, too much testosterone there. So it helped to have it co-ed. You know, so we tried different things in these different centers, and just about everything we try to see how it works, you know, and then some things are successful and some aren't. Now at the priest cottage, there's no fighting over there. You know, I mean, I never have black eyes or anything over there. But at another cottage where we were trying to have this all-male cottage where they were all pretty active and they would go outside and even try to play baseball and things like that, they also figured out how to unlock the gate and escape. So, you know, I mean, you're at different levels, and so, 5 of those were engineers in that cottage, and they just watched. It had this mechanism with a code on it, which they couldn't see, but they figured it out. And they figured out how to deactivate the mechanism. And so, then I had another patient that was admitted, and he got out. He flagged down the police, told them that, he had, his car was broken down, needed a ride to his house. They gave him a ride to his house, which was his real house, remembered how to get there. And he said, my keys I left back at the car with the repairman, they were on the ring. He thought of that story. So they helped him break into the house. He got into his house. The neighbors called the care center saying, I think Mr. Jones is home. How did he get? And we're like frantically searching everywhere. We got the police out. Well, the police then listened to the report, found out somebody was missing with the same patient. They drove home and helped him break into his house. So this is, we're laughing about it, but that is the heartbreak. Persons don't always want to leave their home, and they can't always take care of themselves at home. And so that's why we try to assess every possible condition that can be treated to keep people in their own homes as long as possible. And then if they have to go to assisted living, to make it as much like their home as possible, to bring their own things. And so as people do lose part of their memory, one of the things we did at one of the facilities, which I thought was a lovely thing, is that they had what they call the memory box outside their door. And inside of it be pictures of what they did when they were younger, their achievements. I was walking by, and this one lady had gotten her license from the Wright brothers for flying, and there was a picture of her receiving, one of the first women that got a flying license, and the Wright brothers were in the picture. And some people have beautiful paintings in their rooms that they painted, but now they can't paint, but they still like to do activities like that, but they can't paint that way. Some people like music and others don't. So you cannot just do one thing for every person, because a lot of it's dependent on what they like to do before. So we asked the family that, well, what did they used to like to do? What were the things they really enjoyed? And this one lady, what she really liked to do was go out to lunch. And after, we do that at least once a month. They all go to a restaurant if they're able and physically can. But that wasn't enough for her, because she used to do this pretty often. So what we did, since there's like 8 cottages, she would get dressed up and go to another cottage for lunch every day, and that way it was like a different restaurant, because they're all different colors inside. And so that made her happy. Well, then she broke her arm, and I had to have a splint put on, and she came back from the doctor, and the doctor had not put a cast like I asked. He had just put the splint that you can take off. So I said to him, she's taking this off, it's not going to heal. He said, well, put duct tape or do something. Well, here she is, dressed to go to lunch. You're not going to have duct tape on there. So no matter what I did, she'd get it off. So then she went to the doctor, and he said, I can't understand why this isn't healing. And so I said to her, Mrs. Smith, why can't you leave this on? It doesn't match my outfit for the day. So I said to him, can you put a green one on, or a blue one, a pink one, something, and we'll try to match her outfits with it, But, because she had plenty of time to figure out how to get this off no matter what I did. I even tried the duct tape, but it didn't work. She had that off in 5 minutes. But, I just want them to be happy and have as normal a life as possible. And so the more we find out from the family members of what they like to do, we try to build that into their agendas and into their everyday activities. But staying active, participating, being with other people, doing as many activities that they feel they enjoy, keeping them mentally stimulated, socially stimulated seems to make their life the best.
First of all, how expensive is Ariset? Secondly, what agencies other than the Department of Welfare, for those people who are eligible for welfare, covers the cost of the care of these people?
There are some, the assisted living facilities range from $2,000 to $5,000 a month. So that's why I decided I better take out long-term care insurance, because I'm starting to have some memory failure now, I think, so I figure if I start paying at this age, but be sure you get the kind with the inflation clause, So, but that's something to think about. Because I live alone, my family's in a different state. I know they have, my sister has a child with a Down syndrome. It's not like she's going to be able to take care of a sister with Alzheimer's disease too. So looking ahead, I thought, I better do what I can now to make sure if I ever need this kind of care, Because it is a financial drain on the families, you know, if they're thinking they're only gonna live for 2 or 3 more years there, and then 5 or 6 years later, they're still healthy and still doing well. You know, this is a long-term type of care. Access does pay for some care. At some of our facilities now, they are holding beds for a certain number of access patients, whereas before they wouldn't pay for them to be in assisted living. And now they are changing the rules. So I think that working with the Alzheimer's Association, they do a lot with the legislation. They were the ones that got the care units. We just had nursing home before '95. We've had people come from other states just to see the assisted living care facilities for Alzheimer care in the state of Arizona. We were the first to start that. And that's just mushroomed. I mean, in '94, we probably had those 10 units and that's it. We must have a couple hundred now in the valley. Not all are as good, and the Alzheimer's Association does try to give information to persons concerned. So you might want to have a speaker from the Alzheimer's Association because they have more of a handle on the legislation. They keep track of cost of things, what you can do, you know, actively, politically to make care better, because it does affect a large number of persons and their families. So that could be another speaker for you.
How expensive is Aristep?
Aristep, I don't have my little formulary with me and my memory's not that good, but because I don't do the billing part. But I'm thinking it's like, $100-something a month. I mean, who has their family member on it? Maybe you could tell us how much it is. I think it's $100-something a month, but see, if they have more than one medication, it depends on their insurance plan. You could easily have, between that and their heart medicine, all that, several $100s a month in medications. I'm not sure who was next. Okay.
I was going to say, what do you suggest when you do have someone living by themselves independently, but you are seeing as a family member these signs? How do you go through, when do you make the determination that they really need more help when you aren't living with them on a day-to-day basis?
Well, that's some of the things that families are not always aware of, especially if they live out of state or even in a different city. So I think you need to talk with people around them, their friends, their family members, not family members, but friends and neighbors, to see how are they managing. I think you need to look at their general health to see, are they maintaining their body weight? You know, can they still get meals, or can you have Meals on Wheels delivered? I think when the person wanders away and gets lost is a real fear. So you have to be on top of that, is how much orientation they have. And where do they live? I mean, some can live in a regular assisted living apartment where the people know them, but I've had calls saying, you know, my mother was at assisted living that was non-Alzheimer care. And pretty soon neighbors were saying, you know, we have to always remind her when it is time to eat. We have to take her to the dining room. Sometimes she gets very agitated, upset. So then they knew it was time to move her to a facility. And they found that out from her friends and her neighbors. So I think it's the people closest to them that will see those subtle changes. But as I said, my own good friend who was teaching called and said, I got lost driving. And I think, you want to tell them about your sisters? When did they notice their symptoms and they decided they couldn't drive anymore, but they're still at home now?
The older one decided she had memory defects and went for testing. And she wasn't told that she had Alzheimer's at that stage. But she managed, we kept her in her apartment for 6 months by my going there regularly every month and then having being escorted to meals and so forth.
Right.
But she had 3 years in a nursing home, which cost over $200,000.
Yeah, she said the nursing home cost over $200,000 for 3 years. And so that was very expensive. But they were able to maintain her once they noticed the symptoms, and she was tested for 6 months. And that's usual, that once you find out they have the symptoms of it, they're tested and diagnosed. If they have a spouse, they can stay at home probably for 2 or 3 more years. It depends on their symptoms. If they're up all night and you're trying to sleep and they go outside and wander off, then obviously you need more help, because after a while the spouse's health is going to deteriorate. Or sometimes the spouse develops an illness that needs a lot of treatment. They can no longer maintain taking care of another person. Perhaps they have cancer or they have heart disease themselves. And so they may have to place their loved one in assisted living. But we don't have people there which is early stages. We have people there that are usually moderate to advanced, because the family and the supportive services in the community have maintained them as long as they can at home. So if you're not there, visiting, I think checking with neighbors and friends, make sure they're not, it's safety that we're first concerned.
How morally are we obligated to take care of a person who's drain on the family's finances, they don't know who you are, you're giving them all this medication to keep them going? What is the point in this? At some point you have to say, keep them comfortable without all this different medication like this, keep them.
Yeah, her question is, at what point morally should you stop treatment? And that's for each family person to decide, and I think it depends on how their family member is, what other kind of illnesses they have, what other kind of diseases they have. But I know that people have said, well, since they seem to be at the end stages, they don't remember anyone, why don't we stop the Aricept? That's why I brought that up, that their whole health went down. But, I can't make that decision for persons, but, my own beliefs for me is that I could never participate with physicians who say, oh, good, they have pneumonia, let's not treat it. That is not my philosophy. I have to do what I feel that will keep the person maintained at their highest level, because if they can still walk and they don't have a broken hip and they are not in a nursing home bed, they're able to be maintained at a lower level of care in assisted living compared to a nursing home.
Isn't this a big drain on the family financially and emotionally?
Well, I know that those are the things, and that's why I said the Alzheimer's Association does have a caregivers group in which they discuss those issues, and so I think that probably someone that's from that avenue would be a better person to talk about those kind of things with you, because they have caregivers in their group, and it's mostly those persons. Because I'm talking about it from my viewpoint and what I feel I should do. And the caregivers, that's a different group, and I do help them as much as I can on the everyday issues. But when it comes to those kind of major decisions, then there are other people that help them with that.
And I think that's where the legal issue of advance directives comes in. I think we all have to think about it ourselves. Well, how do we feel about it and get it on paper so that if and when that situation occurs, the wishes of the person are known and the family can make an informed decision about it.
And so, I see with just the questions today, you got 4 more speaker topics.
Let's take one more question and I think we have to wrap up.
Well, thank you for all those questions. I'm sorry I can't answer them all to your satisfaction, because some of those things are still in research, some are things that are personal decisions, but there are other people that can help you more with that, such as the Alzheimer's Association, that do a lot with the caregivers and know a lot about the legal things. There are things we could do to change the system so you can get some more support and help, and that's what I would advocate also, is that families and the insurance companies help out a little more. And there is some changes. Before, persons with Alzheimer's disease weren't eligible for certain Medicare benefits. They just changed that last week. And so the Alzheimer's Association and other associations like that have been really instrumental in getting those laws changed.
If you appreciate the Humanist Society of Greater Phoenix and would like to see more, then subscribe to our channel and check us out on Patreon. Links are in the description.